You just received an award today. How exciting is that?
I am so excited. What an amazing way to start a weekend, right? Cincinnati, women who mean business. I'll take it.
Here's how I think of you. I think of you as a benevolent disruptor that is truly revolutionizing healthcare for women.
That was my goal, to be a disruptor. I like the way you said benevolent, because I've always done it with humility and kindness and very mission driven, with the patient at the core. So I like that. But disruptor is not always welcomed in a lot of circles. You know that. So I'll take that.
I definitely do. And we're here to talk about you, and we're here to talk about HerMD, which is a completely, I believe, disruptive event in healthcare, and something that is evidence-based and completely heals the relationship between not just the patient and the provider, but basically how we communicate. So I'd love to know a little bit about, one, who is it for, and why did you start this? What is the thing that brought you to being this healthcare revolutionary that you are?
I always get emotional telling this story. But, I got a phone call that nobody wants to get, and it was my father saying, Somi, you need to come home. And my mother had been in and out of the hospital for the previous couple of weeks, literally begging her doctors for help. She had left arm pain, shortness of breath, chest pain, and she was told, oh, too much caffeine, or your children are stressing you out. And she ended up getting rushed in for emergent quadruple bypass surgery. So that not as one artery, 2, 3, it's 4 that were occluded. And so she had life-saving surgery. So she's alive and well to this day. But I was pre-med at Northwestern at the time going, aha, this is my calling, right? I'm going to be an advocate for women. Flash forward, medical school, residency, get my first job. And the realities of our very, very broken healthcare system, the same system that nearly cost my mother her life, smacked me. I mean, that's the word I'm going to use. Smacked me in my idealistic face. I didn't have time to eat or go to the bathroom, let alone be an advocate, right? And so just shy of my 40th birthday, I told my husband, I said, I'm either going to stay home because I felt like a failure. As a doctor, I was a failure. I wasn't listening to patients. I wasn't giving them the time and attention they needed, and forget what was going on at home with my children. So I was like, I'm either going to stay home and raise these beautiful babies, or I'm going to open a center. And I wrote down 3 words: empower, educate, advocate, where women are partners in their healthcare. And my husband jokes, but he's like, good God, woman, you will drive us all bananas if you stay home. And so, I tried to take a business idea to a bunch of hospital systems, and they said, it'll never work, and so I went to my father and I asked for advice, and he said, if you can't find an open door, build your own damn door. And that was the first HerMD. 2015 in Cincinnati, Ohio, a center for menopause, sexual health care, and gynecology.
Just amazing. So you started with one. You opened your own place.
Yes. And then saw women coming in from 35 states and 3 countries to Ohio and Kentucky, which was eventually our second location.
And when you did this, was it just you, or you had other doctors with you too?
I had a team. I had a nurse practitioner, and I did have another doctor with me. I think the biggest thing I had were other dreamers and people who believed in the mission, and people that were frankly smarter than me, right? I had not fundraised. I had not made financial models. I didn't know how to build a brand.
Amazing. And so what was it that brought these women from 35 states and 3 countries? What was it that you were doing so differently? Obviously, you were putting it under one umbrella. You were putting OBGYN, sexual health, and menopause under one umbrella, which is massive. But what was the thing that drew all of those women there?
Menopause, sexual health care, and gynecology with an insurance-based system, with experts trained in these areas, right?
Yes.
So less than 20% of OBGYNs have training in this area. And we took insurance, which is unheard of. And 20 to 60-minute appointment times. What the what?
Right.
Is what women were saying. That they got more accomplished in one visit with us than in years of seeing their doctors.
Years, because as you know better than really anyone, when we go in to see our doctors, we better have our questions like right then, and we're going to be under pressure and it's going to be rushed, and then we're going to leave and we're going to be like, wait, what about this? You don't get anything accomplished. You kind of you end up leaving with more questions than answers.
Well, people always ask me what the biggest barrier is to amazing healthcare, and it's time. Doctors don't have time, providers don't have time, patients don't have time. Particularly when you're talking about menopause and sex. I mean, these are intimate, personal issues.
They really are. They are, and they need unpacking. Like when I go in and see my doctor, I have a list. And that list is like, oh, ask about my knee, ask about my hip, ask about this. But when it comes to sexual health and it comes to subjects where we actually have huge gaps, not only in our own knowledge, but also where our doctors have gaps in their knowledge because it's not taught in medical school. Those are the things that we do need unpacking on the sensitivity side and just on the fact that we have such a gender bias in healthcare.
And how about the fact that we maybe don't want to be naked when having these discussions? So I'm serious, right?
Oh my
God.
God.
Room, get undressed.
Yes.
You have 6 minutes. And it's like, do I really want to talk about my low libido when I'm already undressed with a complete stranger? No.
Thank you.
We do.
Thank
so
you.
Our healthcare spaces do not facilitate honest conversation.
Oh my God.
Right? Yeah.
That is so true. And actually, that's not something I thought about. When you are like, oh, okay, get all undressed. The doctor will be in here in a minute. You're in that paper thin gown with your little, feet dangling, like you feel like almost like a little kid. And it's very disempowering. It's really disempowering. That's so true. It's like stripping you from basically kind of all of your dignity in a way. And that's no way to do it. So when you see your patients, first of all, how do I become a patient? Do I just go to your website? Do I call? Is there a waiting list? What's the situation?
There's multiple things. So there's the website, HerMD.com. You can call. We are in 5 states now. There were very long waiting lists when we launched in each market, but we are tackling those because we do not want that to be another barrier to care. Our lighting is low in our offices. You'll get a beautiful robe, a parachute robe.
Ooh,
yes.
Wait, are you serious? You get a robe?
Yeah. Yes. I mean, you don't take it home.
That's okay.
But you have a place to hide your underwear. A real drawer.
Really?
So you're not like,
Yes.
These are.
Oh my God, I had no idea.
Think about it. You don't want to go to an ugly dressing room and put on a beautiful ball gown, right? And so same thing. We wanted to eradicate barriers that existed for women so that they could have authentic conversations.
What color are the robes? I just need to know.
Oh, rust, green, marigold.
I like it.
Yeah, they're gorgeous.
God. All right, and are we sitting in an office setting?
We are sitting in the exam room because we purposely
but we're like sitting next to each other.
Yeah, yes, we're chatting, we're talking.
I like it.
And our doctors do not take their computers in the rooms with them because that is also another barrier to communication. Well, because I once went to a doctor who didn't even turn around and look at me and was just typing away. Yeah. And I felt like I was dictating to a secretary. Like, what is that?
Well, that's how it usually is.
Our physicians are trained, evidence-based. We're doing research. We're data-driven. We're forward-thinking.
Oh my God.
We don't have provider bias. And then you're in a beautiful center. I mean, it's a pretty good place. I'm pretty proud of what we do.
When you talk about provider bias, what do you mean?
So right now in this country, there's up to a 10-year delay in diagnosis for women. If a woman presents to the ER, she will wait longer for pain medicines than a man. There are 26 medications for male sexual dysfunction and only 2 for women. A lot of times our pain is not believed. Yeah. And we're more likely to die at the hands of a male provider from cardiovascular disease. And so, and so we wait 4 years longer for diagnoses than men. And it's because our pain, our symptoms are often dismissed, like my mother. And let's get to the root of it. Why? There was no data. We were not included in clinical research trials. And let me hit you with this other gem. The Latin root word for uterus is mitra. When we remove a uterus, what do we call it? A hysterectomy.
Hysterectomy.
Right. Why? Because you're going to remove a woman's hystericalness.
Just, oh my God.
From the vocabulary
Oh, wow.
to the lack of education to the lack of data. Yeah.
And the words we use. You're reminding me of a fabulous New York Times article that I will send you and that I will post as well, that talks about, I'm forgetting the writer, it might be Rachel Gross, but it talks about the root word of pudendum and actually translates to the thing you should be ashamed of. And I was, of course, looking into this for pussy and where that comes from, which is actually French and it comes from kind of pocket. But pudendum, that thing you should be ashamed of. That's such a huge, huge, huge part of why we're not heard, because all of these things have been put in the bucket of, oh, she's crazy. Like, oh, she has her period, so she's crazy. Oh, she doesn't have her uterus, so she's crazy. Oh, she has her uterus, so she's crazy.
And I was part of a renaming revolution that took place. Worked with a linguist and a psychologist and took out a lot of the harmful words in medicine.
Can you say more about this? What kind of words did you take out?
It was like a habitual aborter is a word used for someone who has frequent miscarriages. I mean, how awful is that? Incompetent cervix, a geriatric pregnancy, poor maternal effort.
Poor maternal effort?
Yes, when a woman is really, really tired and she's pushing. So you say, oh, I'm doing a C-section.
In labor?
Poor maternal effort. It's like, that is one of the hardest things you will ever do in your life. And that's what we're going to judge women on. Incompetent cervix. I mean, really? Yeah, no, this was in our electronic health records, our medical textbook.
I'm like stunned right now. So where does this stand now? Are these now changed?
Yes, some are changing. It's been downloaded, I think, over 50,000 times by people, by medical students, by residents, and hopefully it'll change in all of our, electronic health records. But historically, provider bias, most OBGYNs were men. So they looked at women for two outcomes, so babies or vessels for male pleasure.
Oh my God. Uh-huh. Yep.
So
just wow on that. How that's changing now, thank God, because of you and other people that are in your same camp. How can you preach to the unconverted? How can you really educate the other doctors that are out there?
I have started something internally called HerMD University, which is a classroom to clinic experience, which takes data and turns it into real world clinical practice. And by sharing stages, working together, doing things like this, talking about it, we're going to eradicate barriers.
Where do you find your people who do have the training? Because I'm seeking out for this show all the people who have the training. Like if you've got the training, and that's why I ask you, like, where'd you get yours? Because I know you didn't get it at medical school. And so where did you get yours?
From my patients. 20 years of field research.
That's the best way.
Number one. Number two, conferences, preceptorships. So we don't find them. They come to us, 100-person wait list, and we train them.
That's amazing. So you're really writing the curriculum for this.
I've written it. It's done. It's digitized.
This is so exciting. Oh my God. And then would something exist in the future that could come from this, which would be for patients as well to be able to learn more?
Oh my God. Are you in my brain?
I don't know. Am I?
I think you are. So yes, we're already writing it.
I'm so glad. I'm so glad because this is what I've been thinking about so much.
And it will be free.
No.
For patients.
Hallelujah. Hallelujah.
Yes.
As it should be. I believe education overall should be free, because the more we're educated, just the better citizens, the better humans, the better mothers, the better patients, everything we are. These are the things that I have tremendous gratitude for. Like we're in November, I'm thinking about gratitude, and we're in this like gratitude series of the show. And I'm like, we are scooting this one up and we're putting it in there because this is what I'm so grateful for. I'm so grateful for people like you, like Dr. Rachel Rubin, like honestly, everybody who's been on this show who are absolutely changing policy, like changing actually how we exist in the world, how we take care of ourselves, how we can be a part of a really successful patient-provider relationship. So tell me where you exist now.
Ohio, Kentucky, Tennessee, Indiana, New Jersey.
Okay, love it, love it. And that's actually brick and mortar. I can come in like knock, knock. I'm at the door. I'm wearing the robe. I'm wearing the socks. I'm sitting with you for many more minutes than 5. We don't have a barrier of a computer. How about online? Do you offer any of those services?
Yes, obviously anything that doesn't require an exam. So we're integrated, both brick and mortar and virtual.
If I'm here in California, which I am, can I talk to you about, like, let's say my hormones? Do you send me to go get a blood test and then you look at those results and then we talk about them on a telehealth?
Yeah, so we're limited by states, obviously, with the compliance. So some states, yes. So we work with LabCorp. We can send orders for imaging. We can do all of that virtually.
This is the thing that is kind of core to my mission with this show is so many women are in this perimenopausal and menopausal place. And I mentioned recently that I didn't think I had heard the word perimenopause until I was in it. So I'm not even kidding. I'm not kidding. Where we're like, oh my gosh, why does this hurt? And why is this off? And why is all this stuff changing? And then we're being given maybe an antidepressant or maybe a anti-inflammatory, right? All of these different things, being told to go sit in an ice bath, who knows? But for something that can be totally addressed with a hormonal shift. So one of the goals that I have is telling people where they can go to get treatment. And if they're not in Indiana and they're not in Ohio and they're not in New Jersey, I would call your office and say, hey, here's what I'm looking for. Are you able to help me? I'm in this state. And you guys would be able to tell me yes or no.
Yeah, as does Ishwish and Menopause Society, right?
They're a phenomenal resource. So that's something that is important. I'll also put in the show notes because I don't think enough people know about Ishwish.
Yeah, that's where part of my training occurred and a lot of our providers' training occurred. So great evidence-based medicine.
Can we just talk about your victory, like just your massive business victory in terms of being 3 minority women going out and getting traditional funding and having, let's see, I think it is less than 0.5% chance of getting it and then completely knocking it out of the park?
Yeah, so 3 minority founders from the Midwest told you have less than 0.5% chance. We were oversubscribed, not once, but twice, and now have raised $30 million. Woo!
Like, I could cry. Like, seriously, it's so exciting. Like, that.
I cried. When it happened and all the term sheets came in, I cried. I got a term sheet from my first pitch. They were like, it will take 100.
Unbelievable. Just it's really just like, oh my God, like it's actually happening. You are just paving the way for so much goodness, so much benevolent disruption.
Yeah, and our investors were all male, which made the headlines. We got men to care about women's sexual health. And I was, I was like, yeah, all right, okay.
Yes, because I believe they want to.
They want to. And they've all had a mother, sister, daughter, someone affected, right, in healthcare. But when we showed them the map of 35 states, see, I get emotional.
Yeah.
They're like, oh my God, right? Blue ocean opportunity. Like, what is going on? Ohio's fun, but I mean, it's not all that exciting. And when you get women traveling, you're onto something.
And so and I know we're going to get to this, but now I'm like, oh my God, is the goal to be in all states? Is that where you're going?
200 locations. If you're going to do it, you might as well do it right.
Thank you.
Right.
Here's what we say in Texas, and that's where I'm from, is you go big or you go home.
Right.
So I'm all about it.
I'm a workhorse going for unicorn status.
Yes!
That's what I say.
I love this.
Yes.
Oh.
Yes. 200,
you know what?
my friend.
The market is dictating what is so important. So you can't argue with that kind of data, which is women coming from everywhere to be listened to be heard, to be cared for.
We had a 1,200 person wait list.
I first met your head of marketing actually at the Menopause, and I remember like picking up, something about HerMD, and I was like, oh, like, tell me about this. And I was just like, wait a minute, you offer insurance? Wait a minute, you're actually a brick and mortar facility? Like I can actually come there? I was like, okay, you gotta be kidding me. I was like blown away. And now I know your entire family. And it's your mother-in-law who's the marketing materials, right? Or is it your sister's mother-in-law? Sister's mother-in-law?
Her sister's mother-in-law, yes.
Sister's mother-in-law, who's a lovely woman.
She's a badass.
Incredible. Just incredible. She is.
Yeah.
She is. All right. Another huge victory, and you've had so many, and we talked about the press you've been in. I mean, you've been in Vogue, and is there anything you haven't been in? I mean, really, is there something that you'd like to be on the cover of that you are not yet?
Oh, I would like to meet Oprah and get on Oprah's show.
Right?
Yes.
Yeah.
Cover of?
Yeah.
Oh God, Time, Fortune, Disruptor.
Yeah. Yes.
The person who truly changed healthcare, truly gave women access. That's what I want, because that's the goal. It's not to get famous. It's to truly make sure women stop dying, losing their jobs, walking away from the bedroom and the boardroom, that they know that they matter, that their stories are heard.
That they're not suffering in silence, and that they're not being told that they're crazy. I'd love to see that. I'd love to see that for this never to happen again, for a woman to never ever be told again that because of something she's feeling in her body, that she's told that she's crazy. I think that is just a travesty.
Cheers to that.
Cheers. All right, let's talk about the papers that you just had published and that you presented at the Menopause. You presented at Menopause Society?
Yeah. So first was we Botox people's vaginas.
Yes.
Yeah.
It's not just for your forehead anymore.
No, it's not. And it has lots of medical indications, but not yet for your vagina, which is very frustrating, because women can struggle with something called vaginismus, which is, so basically, let's make this clear. It's not for cosmesis. Okay. We're not trying to make your vagina pretty. Your vagina is pretty. But involuntary contraction of the muscles surrounding the vaginal opening that render exams, tampons, or sex impossible. So we Botox these women with a 95% success rate in our surgical center. So they're sleeping. And
good. We're sleeping. Fantastic. So no pain.
No pain and no memory
Hallelujah.
Of this.
Hallelujah.
But they get back to sex or to sex for the first time in their lives. Exams, tampon use. Huge.
Wow. Wow.
And I would say a couple years ago, a paper like this would never be presented at a conference like that. So that's change, that's huge. Couple hops on a flight, comes to Cincinnati.
Yeah.
Married 8 years, never had sex. Botoxed her. Later, got flowers and candy. They're having sex. I mean, that's a game changer.
It's huge. It's just huge.
When people stop having sex, they lose relationships. And so
they do.
Sexual healthcare is healthcare. We both can't be this emotional.
We can't. That is the tagline of this show, because I'm like, look, learning about women's sexual health is healthcare. Just learning about it. I think we're headed in the right direction if we're talking about it, if we're learning about it, if we're curious about it, if we're asking questions, if we're showing up at a conference, if we're watching a podcast. I think all of it is healthcare.
Absolutely. And then the second paper was about GSM.
Yeah.
Genitourinary syndrome of menopause, right? Incontinence.
Yes.
Frequent infections, sexual pain. And we used radio frequency and electromagnetic stimulation and garnered 95% success rates. Yes.
Amazing. Okay. Which devices were you using? So I was talking to Dr. Yael Halas earlier today. We did an Instagram live about her episode. So much fun. So we were actually talking about radio frequency, and what I like to do is I like to focus on different devices so we don't hear about all of them all at once, because I think it's overwhelming. So what are the devices you talked about?
So we use the Empower, and it's got multiple hand pieces, either radio frequency, microneedling, or the electromagnetic piece of it. And so, yeah.
That's like a Swiss Army knife. The fact that it's not using the same modality, but in different places, but it's using different modalities with one core kind of, I'm assuming kind of one core machine.
One platform, different hand pieces. Yeah. Yes.
Ooh, okay. Let's talk about that. Let's break it down. So I want to come in and I'm like, tell me about the Empower. What can it do for me? What kind of problems can it improve?
Sexual pain, incontinence, pelvic floor health.
Okay.
The way it's helping the pelvic floor is causing 11,000 Kegels in one setting. It's the V-tone.
Ooh, the V-tone. Okay, let's talk about the V-tone. I'm so excited.
Emsella you sit on, right? And you try to position yourself. Yes. It works. It's great. Yep. V-tone looks like a little egg, but it's placed right in the vagina. So you can really target those muscles. Inside. Mm-hmm.
Oh.
But it doesn't hurt. Oh, wow. Okay. It doesn't hurt.
How big? The size of an actual egg?
About. Yeah, that's what I would say. Yeah. Okay. So it's placed in there with lubrication.
Wow.
Takes about 15 to 20 minutes. And we just power it up slowly as you tolerate it. Start at a really low level. Okay. Because sometimes it is it's one thing when we're doing Kegels on our own, but like when a machine is forcing your body to do a Kegel, it takes a moment to go, oh, okay. And then we just keep increasing the energy. And this is exactly what people's faces are like. They're like, oh, okay. And so I preferred that to the Emsella because it really, as gynecologists, we examine our patients anyways. We have them undressed. And so rather than trying to force a woman to position herself, we position it for her, right?
Got it. Makes sense. It does. Right. It makes sense.
And before we place that, though, we use radio frequency to warm up the tissue, and then we put the V-tone in with a radio frequency handpiece. That's called Forma B.
With a handpiece.
With no microneedling. So your provider's actually in there, kind of. I like to use the word painting, kind of painting the vaginal walls. Painting, right? Sounds much better than
not painful,
placing, pushing. Not at all.
Now I'm very curious about the V-tone. Now I want to come see you put on the robe, and I want to do the V-tone too. So you get a little warmed up, and then here's this little egg, and you put the egg inside, and then you're right there with me, or one of your one of your colleagues is right there with me.
The medically trained staff is with you, and they're asking you if you're okay.
That's going to really address incontinence, right?
Incontinence. That's really going to address the incontinence piece. And the pelvic floor laxity. Great. So if you're not having the greatest orgasms anymore, the pelvic floor isn't strong anymore. Sure. It can actually help with that. It's not indicated for that. You know about the FDA, but it can definitely help with orgasm and overall pelvic floor strength. Yes. So the other hand piece combines radio frequency and microneedling, causes a controlled injury, right? Body goes, I got to repair myself. Lays down collagen, increased blood flow. And you actually look at biopsies before and after of the vagina. And it's pretty amazing. Becomes much thicker. And so I talked to you about this earlier, but we want our vaginas to be like accordions with these deep folds called rugae, so we can stretch and accommodate for our partners. As we lose hormone, go into menopause, that tissue thins. We lose those folds. Becomes like a tube sock. We can get micro tearing or burning or pain with intercourse. And so we want that tissue to be thicker and have collagen and elastin. And that's exactly like, how women get radio frequency and microneedling to their face? Same thing for that vaginal tissue. The whole device is called Empower. That handpiece is called the M8V, for vagina. And so once again, a paper like this a few years ago And in fact, they were steering people away from using, energy in the vagina because it was in the wrong people's hands, because too many people were using it.
Sure.
They didn't know what they were doing, causing injury,
Absolutely.
right? We don't want to cause harm.
Yep.
But now this was welcomed. And, much larger trials need to be done. But think about it for people in conjunction with vaginal hormone instead of cancer survivors, those who haven't tolerated it before. That's an amazing optionality, right, to have.
It really is.
Yeah.
It really is. It really is. All right, so we've got the egg part of it. Then we've got the other hand piece, which is causing the minute injury, just like if we were to laser our faces. And then is there a third?
The third one was the one that just warms up with no needles in it. That's called a Forma V.
Got it.
Yeah.
All right, the Forma V.
Yeah, and that just makes the V-tone work more effectively. And then there is a hand piece, just the M8, that we use externally, because people have vulvodynia or vestibulodynia, external pain.
Yes, can you tell what that is?
Yeah, okay, sexual pain, 3 places: outside, vaginal canal, pelvis. So a lot of women, because that outside is so dependent upon hormone, both estrogen and testosterone, in menopause will present, that's one of the reasons, with vulvar pain. And the M8 is the external handpiece, radiofrequency with microneedling.
The external. So we're putting that on labia?
Minora majora, vulva, and vestibule. You can even use it on the clitoris.
We do have so many options, and that is thrilling because we might not have in our city a doctor that has the V-tone, the Empower, but we might have someone who has the MFM 360. So I think it's good for us to know all the options. What are the pros and cons? Why is this one better? And then make your own decision.
Well, when you have so many optionalities for men, I always ask, where's the penis going to go in relationships that are a man and a woman, right? We know there's all kinds of relationships. But I asked my urology friends, and that's why I love Rachel so much. She gave a lecture once, like all of a sudden there was a penis in the room. It's like, okay, where is this going to go? This is great. And so many patients come to me saying, we were fine, but then he got Viagra. You have to help me. So it's the impetus, but it should have been happening along the way, right? Not, oh my God, now there's an erection in the room and it hurts. It should have been counseling along the way. That people are missing that biopsychosocial approach. Relationship, hormone, medical history, pelvic floor, hormone. It is a very, very broad approach. Yeah.
So true. Like right now, it really is siloed into here's your, let's do your annual pap smear. And there's nothing about, how are you feeling? There's none of the biopsychosocial approach that you have in your practice, which puts OBGYN, sexual health, and also menopause under one umbrella. That I think is just the absolute game changer. But you touched on something that I want to make sure we touch on, which is when you talked about, relationships, a relationship where it's a, man and a woman, like where's the penis going to go? But something I know exists is a lot of bias that is hurtful to people in the LGBTQ community. And I know that is one of your tenets in terms of your mission is to make your practice a safe space.
Yeah, so obviously there are certain populations that we can and cannot take care of because we specialize in GYN. But that being said, we really, with education and sensitivity training with staff, take approach of an intersectional framework that examines the interplay of race, culture, ability, gender, age, everything, and curate someone's healthcare journey so that from the front door to the exam room, they're welcomed. And we understand that there are disproportionate barriers to healthcare. And we want to eradicate those by first and foremost a treatment plan that's curated for an individual, combined with a very welcoming space. And I think that is what we've really done at HerMD, through education of our entire staff, and also making sure the patients feel very welcome and not isolated. And that's what they say, that they are so happy that they found a space where they can come get their health care, where they're not judged and there's no stigma, taboo, or shame. And listen, it was not an easy task. I'm in Ohio, Kentucky, Tennessee, Indiana. We're not in LA. We're not in Miami. You know, most providers and staff want to take care of all patients. They just haven't been taught, you know? And so once you do that, then it's an amazing experience for both provider and the patient.
And I'm sure that you're including this in the HerMD University curriculum.
Yes, I'm telling you, you're in my brain. Yes, it's in the curriculum. Yes.
Is so important. You reminded me of a conference I went to years ago. I worked in healthcare for 6 years, actually on the aesthetic side. I put artwork all over hospitals, all over Indiana, actually, in 2 million square feet of 7 hospitals all over Indiana. And it was an honor to work in those hospitals. It really, really was. But what you're reminding me of is when I was in that time of my life, I sought out training everywhere. And one of the trainings I sought out was at Stanford in their CCARE, their Center for Compassion and Altruism Research and Education. And they were doing compassion cultivation. And so I was listening to all of these doctors talk about the fact that they wanted to be compassionate to their patients, but they couldn't because they didn't have enough time. So I'm so happy that you're doing that.
I am beyond thrilled with the results and the outcomes, of what we've done. It's pretty amazing.
I know that you're on your way to having 200 locations, and you're a mom, and you're a wife, and you're winning awards like all the time. And so how are you doing this? You're increasing your team, obviously. You're getting the word out clearly, which is phenomenal. You're changing the face of healthcare. The sky is the limit, but how do you keep your own balance?
Oh, I have a continual sense of wonder. I'm an avid traveler. So I love to travel.
Ooh. Yes.
Yeah. So you will find me on hiking trails. I was just talking to my daughters about weekend. Yoga, working, movement, being outside, but planning trips and spending time with the people that I love and that fill my bucket so that I can continue to be a bucket filler for everybody else. Is huge for me. And the other thing people are shocked is that I'm an extroverted introvert. I love to talk. I love to do the thing, do my thing. Like you said, press, TED Talk, national TV.
Sure.
But in my, time when I'm not doing that, you'll find me at a quiet dinner with friends and a great bottle of wine, or on a hiking trail, or exploring. But I love to travel. I've been blessed to be all over the globe. And I feel like a child when I travel, because I feel like the world is our biggest classroom. Absolutely.
Absolutely. I could not agree more. That's what I've invested so much of raising my own kids in. I did a 4-year travel curriculum with my son. So I took him in a different place every year of high school. And the criteria was we had to go to a place where neither one of us had ever been, and we had to do things that neither one of us had ever done. So it was taking us out of the I'm the teacher, you're the student relationship, so we could learn together. And we made a pro bono documentary in Africa. We meditated with monks in Bhutan. Oh my God. We went around Iceland without a map, and we went skydiving in New Zealand. So each one had a theme. And I could not agree more. I believe it's one of the things I'm most proud of in terms of raising my kids. And then I did something a little different with my daughter. I took her out of school for a year, wrote a curriculum, and I global schooled her. So I was her mom, I was her teacher, and we did that for an entire year. And oh my God, I am so glad that I listened to myself on that, because you don't get that time back. And now my son is 27 years old, and now my daughter is 17 and leaving for college in just a matter of months. And I'm like, oh my God, they both are truly what I call global citizens, people who actually see the bigger picture. So you're now in my brain, because that's how I feel about travel. It is the biggest classroom, and wow, does it give you perspective.
And it made them so close. All of our staircases are covered with pictures, and you've named some of our favorite places. Iceland, we've been to multiple places in Africa. New Zealand is where I want to go for my 50th. I'm 48 years young. If you've never been to Galapagos, that was a game changer for my children. They absolutely loved it. We went there last year. And I also have a 17-year-old, and she just found out today she got her first college acceptance today. So I have a 22-year-old son, 17-year-old daughter, 14-year-old daughter. Yeah, so she got her first college acceptance letter this morning. So she was very excited. She's like, okay, pressure's off. At least I'm into one school. I'm like, wonderful. That's amazing. I'm so proud of you.
Oh my gosh. Same here. My daughter got her first the day before yesterday, and they also gave her a $50,000 scholarship too. Whoa, and she was so worried. She's months ago she's like, oh my God, am I going to get in anywhere? And I was like, oh my God, yes, you are. Like, please don't worry. And I'm so happy too that the pressure's off, and I'm so proud. I just could not be more proud.
So proud, so much to celebrate. And so goals for me and what we're going to do, hospital relationships, enterprise relationship. So working with employers, they're reaching out to us now. Women lost $1.8 billion in lost work because of menopause. Come on.
Wait a minute. You got to say that statistic again. Do that statistic again.
$1.8 billion lost in work-related losses to women because of missed work, because of underdiagnosed or undertreated menopause.
Okay, that is absolute insanity.
And do you know why? Because of vasomotor symptoms, hot flashes, incontinence, so all the things that all of the menopause providers are working to treat. So menopause is not a lifestyle issue. Yeah. So we're now trying to work with employers because they're coming to us saying, how can we help? And that will help us expand much more quickly. And then obviously, I will be knocking on a lot of doors next year because we'll be fundraising again. So, yeah.
Just thrilling. Oh my God. Just awesome. All right. Where can people find out more? What is the website? What is the best place to know more about HerMD?
Yeah, so we are on TikTok. We are hermd.com. We are on Instagram. And then if you want to follow me, I love posting education. Somi Javaid MD. And I'm on Instagram. I'm on LinkedIn. So please follow us.
Great. Yes. And I'm so happy we can now learn so much from social media. I was telling Dr. Annika Ackerman, who we did a show really all about UTIs and incontinence. And I learned about her because she wrote to us, and I started watching her TikToks, and I was like, I've learned more in the past 5 minutes watching her TikToks than I knew, before I showed up. It was awesome.
It's pretty amazing, but it's going to change with the next generation. Look at the article today that just came out that I was interviewed for called Menopause, and how this next generation is not going to tolerate the things that we did.
I love that.
So it's pretty amazing. Yeah, it's called Menopause. I was like, okay, I like that. Yes.
I like that a lot. Mm-hmm. I just did one in Parents Magazine, which was about basically how to talk to your Gen Z kid about sex. Mm-hmm. And I agree. I think they're not going to tolerate so much of the stuff that we put up with. Mm-hmm. And thank goodness. I mean, yay. We're blazing that trail for them.
Absolutely.
Oh, thank you for what you do. Thank you so much for, I could just get choked up talking about it, but thank you for being the benevolent disruptor that you are. And thank you for changing the face of healthcare.
Oh, thank you.